Hypertensive disorders in pregnancy. There's three main disorders that we're talking about in this slide. We have gestational hypertension. Sometimes you will hear it referred to as pregnancy-induced hypertension, or PIH. It's basically a systolic blood pressure equal to or greater than 140 millimeters of mercury, or a diastolic blood pressure equal to or greater than 90 millimeters of mercury. It occurs for the first time during pregnancy. In other words, when the client was not pregnant, she was not experiencing symptoms of hypertension, only during this pregnancy. It usually will occur after 20 weeks of gestation. There is no protein in the urine. Pregnancy-induced hypertension or gestational hypertension does increase the risk of placental abruption during the pregnancy. It also can indicate or cause premature aging of the placenta. The placenta begins to calcify prior to being term placenta. And then we start seeing uteroplacental insufficiency. This hypertension may resolve after delivery. So for treatment, we're going to consider antihypertensives. We will decrease the sodium intake, make sure mom elevates her feet, and every appointment, of course, her blood pressure will be taken. She will be providing a urine sample, and we will be testing it for protein. Then we have preeclampsia. Again, we're going to have a systolic blood pressure equal to or greater than 140 millimeters of mercury, or a diastolic blood pressure equal to or greater than 90 on two separate occasions. There will be presence of protein in the urine. So basically, we're going to start having all of the symptoms of gestational hypertension, but now we're going to start adding a few more symptoms. So now we do have protein in the urine. Again, it usually appears after 20 weeks gestation. These women are at risk for seizure activity throughout the pregnancy, labor, up to a few days after delivery. She will have what we call non-dependent edema. So it can be pretty much anywhere in her body, especially in the face or the hands. She's going to develop hyperactive deep tendon reflexes, headache. She may have visual changes. And complications of preeclampsia would be eclampsia or the HELP syndrome. The HELP syndrome stands for hemolysis, elevated liver enzymes, and a low platelet level. And another complication would be pulmonary edema. The only cure for preeclampsia is going to be delivery of the fetus, and preferably as soon as possible. But if the fetus is still preterm, delivery is going to be dependent on how severe the preeclampsia is. Otherwise, excuse me, if we're unable to deliver her, she will be placed on bed rest and in the lateral position. Left is best, but right is okay. But she needs to be on her side, never in a supine position, because that is actually going to decrease the uteroplacental blood flow and cause fetal stress. Mom should have minimal stimulation because she has CNS excitability. Dim lighting, there should be no television, and she may receive magnesium sulfate intravenously. And if that is the case, then she will be closely monitored for toxicity of the magnesium sulfate. And then we have eclampsia. Eclampsia is literally defined as preeclampsia with seizures or coma. Complications of eclampsia are going to be aspiration, cerebral hemorrhage, stroke, placental abruption, maternal and/or fetal death. So risk factors for preeclampsia or eclampsia would include a family history, nulliparity, meaning she's never been pregnant before, pre-existing conditions such as chronic hypertension, systemic lupus erythematosus or lupus, renal disease, and diabetes. Potentially, hypertension in a previous pregnancy would be another pre-existing condition. Obstetric complications would be multiple gestation, in other words, pregnant with more than one fetus, a molar pregnancy, or a fetus that develops erythroblastosis fetalis. And, excuse me, the last risk factor would be age extremes. Mom is either younger than 20 years or older than 35 years. Not to say that women can't develop these disease processes at other times in their life, but those are more common. So the HELP syndrome is the complication of preeclampsia. It involves hemolysis, which hemolysis is going to be destruction of the red blood cells. Then we'll have elevated liver enzymes and a low platelet count. It's most often related to severe preeclampsia and usually will occur as a complication. It is a multi-system disorder and it is only resolved, like with preeclampsia, with delivery of the baby in the placenta. The hemolysis that occurs in the HELP syndrome is going to be a microangiopathic hemolytic anemia. So as the red blood cells begin to pass through those small damaged blood vessels, they're going to become distorted, and that will result in vascular damage. The client will experience vasospasms, and now the platelets are going to start aggregating at that site, and that will result in the low platelet counts. It's going to impede the hepatic blood flow and start causing an elevation in the liver enzymes. So as we recognize and analyze the cues, we need to assess our client, making sure that we're checking mom's level of consciousness, her respiratory status, her blood pressure, temperature, heart rate and respiratory status, fetal heart rate, mom's urinary output, and her emotional well-being. Now, the symptoms of the HELP syndrome are going to be similar to preeclampsia, but they can also resemble a viral illness, and this can actually cause a delay in treatment because it's not recognized for being something as serious as the HELP syndrome. So, if we start developing the HELP syndrome, then we develop that hepatic obstruction, which can then lead to periorbital or periportal necrosis or intrahepatic hemorrhage. The client might present with hyperbilirubinemia and jaundice. Signs of impending hepatic rupture can include severe epigastric pain and tenderness, liver distension, nausea, and vomiting. And it is suspected that DIC is the primary process in the HELP syndrome. So now we need to prioritize the hypothesis. We know these women are going to have fluid volume excess related to fluid retention, but they can also have fluid volume deficit related to bleeding because of that low platelet level. They're also at a risk for injury related to the possibility of seizures secondary to cerebral vasospasm or edema or stroke, uh, and liver damage. And then we have a risk of loss of life of mother and or the fetus. And as we generate solutions, we're going to involve the mom in helping with treatment. We need to make sure that we have adequate fetal perfusion, and mom can help track fetal movement by doing those kick counts. Mom can also be encouraged to stay in a lateral position and avoid lying supine. That it will help with fetal perfusion. We're going to decrease stimulation. The client is going to maintain safety of herself and the fetus. She will have adequate fluid intake along with adequate urine output. So the interventions are going to be pretty much the same for preeclampsia. It is important to note that we need to monitor the fetus for well-being. This will include doing kick counts after every meal. This is where mom will get in a lateral position. She'll put her fingertips on top of her fundus or on top of the uterus, and then she will monitor how many times the fetus moves within a 2-hour period. She'll do a non-stress test weekly. We can also do a biophysical profile and serial sonograms to help monitor fetal status and fetal growth. Is the fetal continuing to grow during this stressful maternal time? And we can do an amniocentesis to help determine lung maturity. If gestation is considered to be preterm and delivery is still required, we can administer betamethasone to hasten fetal lung maturity. So, did our interventions work? Do we need to do something different or maybe just tweak our interventions? Every time we do something with our clients, we have to evaluate. So, our expected outcomes of the nursing care would include the client is verbalizing the signs and symptoms of preeclampsia, the treatment plan, and the implications as they specifically relate to her pregnancy. The client remains seizure-free throughout the pregnancy and in the postpartum period. The client and significant other can verbalize and report the signs and symptoms of worsening preeclampsia. And the delivery has a positive outcome for both mother and newborn. So let's look at a case study. The client is a 36-year-old gravida 2 para 1 female at 34 weeks gestation, presenting to the emergency department with complaints of severe epigastric pain, headache, and malaise for the past 24 hours. She does have a history of hypertension controlled with medication throughout this pregnancy. She had mild hypertension with her first pregnancy that resulted in a spontaneous vaginal delivery at term without complications and resolving hypertension. So at this point, with just this information, what is most concerning at this time? This would be the severe epigastric pain, because that can be a symptom of impending liver rupture. It could also be the headache, because that headache can lead to a stroke, because that headache is caused by the hypertension. I'm sorry, my dogs are squeezing the squeaky chicken. Okay, so as our case study goes on examination, the client appears anxious and uncomfortable. Blood pressure is 160 over 100. Heart rate is 110. Respiratory rate is 20. Her temp is 37 degrees Celsius. Abdominal examination reveals tenderness in the epigastric region. No signs of uterine contractions. Fetal heart monitoring indicates a normal heart rate. Her hemoglobin is 10 grams per deciliter, which is low. Platelet count of 90,000, which is low. An AST of 120, which is elevated. And an ALT, which is also elevated. And then we have a urinalysis of 3 plus protein. So now, at this point, what cues are going to be important to note with this client? Well, she's older. In other words, she's 36. Her pregnancy is past 20 weeks. She has severe epigastric pain. She has the headache. She has hypertension in this pregnancy and her previous pregnancy. Her blood pressure is elevated. Hemoglobin and platelets are low. She does have elevated liver enzymes and 3 plus protein in the urine. So, what hypertensive issue is this client likely experiencing, and why? Well, I would wager a guess that she is experiencing the HELP syndrome because of the elevated liver enzymes, the low platelet count, and the epigastric pain. So, what interventions are we going to do for this client? Potentially antihypertensives. She needs to be placed in a quiet room with dim lights, no television. We're going to limit stimulation. She's going to be on bed rest in the lateral position with bathroom privileges. We're going to monitor the fetal status, potentially administer magnesium sulfate, deliver that fetus if the fetus is viable, and betamethasone to improve fetal lung maturity.